This is the continuation of your discussion on decreased cerebral blood flow. Okay, specifically, we're talking about your stroke still or your cerebrovascular accident. Recall that we have been talking about the complications of motor deficits on the previous discussion. So class, let's go to your osteoporosis. Your osteoporosis here would be related to the excretion, or the going out of calcium from the bone due to the immobility of the patient. Take note, class, that resorption of calcium or calcium going into the bone is only possible once the patient is mobile. Meaning, if the patient is immobile, the tendency of the calcium is to escape out from the bone. Okay? So class, one problem or the major problem that you would have in osteoporosis is that the patient would have porous or brittle bones. And class, these porous or brittle bones is brought about with the decrease also of the calcium levels inside the bone. So in the case of our motor deficits, osteoporosis is resulting because the tendency of your calcium is to go out of the bone once it is immobile. So, how can we prevent this complication, osteoporosis? Okay, by doing range of motion exercises to our patient. If the patient will be able to do positive range of motion exercises, okay, that would be of help. Now, okay, if your patient is unable to perform your active ROM, you can ask your patient to perform passive ROM. Now, renal calculi. When I talk about your renal calculi is also related to the increase of blood calcium levels. Again, recall that the calcium is going out from the bone. So because of that, the calcium would become deposits in your nephrons. Now, once your calcium class would become deposits in your nephrons, the tendency is these deposits of calcium will later on become your stones. Okay, would become your stones. So that's why, for that reason, to address this problem, we need to increase the oral fluid intake. Okay, to address the problem of the patient, to prevent your renal calculi, you need to increase the oral fluid intake for ocular, for renal protection. Okay, recall that the common site or the common type, of your kidney stones are your calcium oxalate. Then you also have your contractures and decubitus ulcer formation. So be mindful of your contractures, okay? For you to prevent the occurrence of contractures, your patient need to be placed in anatomical position. Okay, you should prevent abnormal flexion or fixation of a certain joint. Okay, in such a way, class, that if your patient is in the anatomical position, once your patient will be able to resume already normal activities, okay, his extremities, hands are not well affected. Okay, so that's the purpose. Contractures could still be prevented by your range of motion exercises. Then for your decubitus ulcer formation, class, your decubitus ulcer is obviously your bed source or your pressure source, and that is a big no-no for us to happen. So for you to avoid that one, class, you need to turn your patient every 2 hours or even more frequently if the doctor would deem it appropriate. Okay, so class, you need to make sure that there is no presence of decubitus ulcers or pressure ulcer formation. Now, so to address again your decubitus ulcer, turn your patient from side to side every 2 hours. In terms of your elimination disorders, okay, you have your bowel and your bladder problems. So for your bowel and bladder problems, the tendency is for you to educate your patient on having a bowel and bladder schedule. Your bowel and bladder schedule will be able to help your patient, class, ensure that they are defecating and they are urinating on time. Now, if your problem is incontinence for both, you need to ensure that the skin of the patient is cleaned properly, especially if the patient is immobile or unconscious. Because if your patient's skin will not be able to clean properly, okay, you will be at risk of impaired skin integrity problems. Okay, so there will be impairment of skin integrity, and we don't want to be happening. Okay, we don't want that to be happening. Also, for the bladder, you need to check for the frequency and urgency of urination. Okay? If your patient is experiencing a decreased urgency of respiration, or after all, your patient is not if your patient would have, increased frequency and increased urgency, okay, one thing that you can do is to give your patient or to insert catheter to your patient if your patient is not purely mobile, okay, or if not, you can advise the patient to follow a certain schedule, okay, so that the patient will not be stressed waking up in the evening just to urinate. Other than that, okay, your patient would also manifest with sensory-perceptual deficits. So for your sensory-perceptual deficit, an example will be your hemianopia and homonymous hemianopia. Okay, I would like to correct myself earlier, okay, or the previous recording, wherein I said hemianopia. So it should be hemianopia. So class, in your hemianopia, you would notice that one side, okay, there is loss of half of the visual field. Okay, there is loss of half of the visual field. On the other hand, your homonymous hemianopia is same as your half, okay, is missing in each eye. Okay, so it's just the same as your hemianopia, but the half that is missing in one eye is already missing in both eyes. Okay, and that will be referred to as your homonymous hemianopia. Now, if your patient would have this, okay, you need to educate your patient to perform scanning. When I say scanning, for example, on this one, if there is an impairment on this side of vision, you'll be asking your patient to use the eyes here class, which we'll be able to see to move to that side. Okay, so that would offer us benefit. Okay, that would offer our patient the notion that the other side is still there. Another problem that your patient would have is your sensory perceptual deficits. That would include your unilateral neglect or neglect syndrome. So class, in your neglect syndrome, the tendency of your patient is to ignore the area which would have weakness. Okay, so patients would neglect the act, okay, as if portions of their world would not also exist on that part of the body. So that's what we refer to as your neglect syndrome. So, for example, if your patient would have a right cerebral stroke, okay, right cerebral stroke, I mean the tendency is for your patient to have left-sided weakness or left-sided paralysis. So, class, in neglect syndrome, your patient will not be giving attention to the left side of the body. Okay, because the left side of the body tend to be less useful according to the patient. Now, class, to help manage the patient on this part of the condition, okay, you need to ask the patient to do scanning. So when I say scanning, you ask the patient to scan the entire environment before proceeding with an action. And then other than that, you need to instruct your patient as to how to perform, okay, as to how the right arm, for example, could perform range of motion exercises to the weak arm. Okay, that way, class, the patient will be able to recognize. The patient will be able to recognize that there is still another arm that needs to be addressed. Then you have your agnosia, your apraxia, and your paresthesia. Okay, try to review the definition of these terms, class: agnosia, apraxia, and paresthesia. Then, other deficits or other problems that your patient will have is your language disorder. Okay, particularly we're talking about your aphasia. So class, oftentimes when we hear the word aphasia, we only think that there is aphasia is inability to say something. Okay, we talk to about aphasic. Okay, so when I say that somebody is aphasic, we are always thinking that that person is unable to perform talking for that matter. But class, when I talk about aphasia, okay, we are dealing with ability to talk and then ability to understand the language. So recall my discussion under assessment wherein we talk about your expressive aphasia, then you have your receptive aphasia and mixed aphasia. Okay, class, just remember expressive aphasia, your patient would have difficulty on expression. In other words, the patient may understand, however, class, the patient would have slow or no expression at all. In your receptive aphasia, okay, that would be sensory. So class, the patient is unable to understand. Since the patient is unable to understand, he may express, but however, class, the expression would be inappropriate. And then you also have your mixed aphasia, which would have problems on both understanding and expression. Okay, now try to connect your expressive aphasia to the term Broca's and then the term motor. You're receptive to Wernicke's and sensory, and then you're mixed, global, and both. Okay, try to memorize those. Your patient will also be having cognitive and behavioral changes. So class, the cognitive and behavioral changes may include emotional lability. So the patient will laugh or cry but inappropriately. There will be loss of self-control wherein the patient will be swearing or refuse to wear clothing. Okay, there will be decreased tolerance for stress and feelings of isolation. Okay, class, these cognitive and behavioral changes would remind us that your patient are not taking it personally in the clinical setting. However, most of them would be really highly irritable after the stroke episode. Okay, you would become highly irritable after the stroke episode. So with that, uh, we need to understand that the patient experience is because of the disease process and not because they are angry to us. Okay, and then we need to allow the patient to verbalize their feelings on how they perceive it. But we do not allow all the behaviors of your patient. If your patient class would display something inappropriate, you need to call the attention of the patient and tell him or her that you do not like what he did. Okay, so that will be immediately corrected. Then, other than that, there would be memory loss of both short-term and long-term. Attention span is also decreased, and then impaired ability to concentrate, abstract reasoning became poor, and then altered judgment. So when I'm talking about abstract reasoning, these are tests that would assess your ability to identify the relationship between shapes, patterns, or images. Okay? So that's your abstract reasoning. So all of them will be down, all of them will be poor in your cognitive or intellectual challenges. Or changes, I mean. Then, these are the signs and symptoms common in hemorrhagic CVA. So these are the manifestations. You have vomiting, early sudden change in level of consciousness. Then you will have focal seizures. You'll have sudden, unusual, severe headache or loss of consciousness. You'll have buccal rigidity, visual disturbances, loss, diplopia, and ptosis. Then you have tinnitus, dizziness, and neurodeficits. Okay, so these are the signs and symptoms of your ischemic stroke. Okay, I mean your hemorrhagic stroke. But if you would compare that to ischemic stroke, they're almost the same. Okay, other than plus the fact, okay, of course, your hemorrhagic stroke could suddenly progress. Okay, for the other parts here, they are almost the same, the signs and symptoms. Then, the complications of your hemorrhagic stroke. One is vasospasm. Okay, so class, your vasospasm may occur 3 to 14 days after initial hemorrhage. So the signs and symptoms would include worsening headache, decreased level of consciousness, and then new focal neurodeficits. Okay, so class vasospasm, there will be a problem on how blood will be transferred going towards the brain. Now, the drug of choice for this one class is your CCB. Recall that your calcium channel blockers are capable, class, of addressing your vasospasm. Okay? Now, you also need the triple H therapy for your vasospasm. When I say triple H therapy class, fluid volume expanders are needed, okay, for your hypervolemia. Then, there could be hypertension for this patient. And then, you need to hemodilute the patient. So again, the 3H for the management are hypervolemia. Okay, then you will have your hypertension and hemodilution. Okay, in other words, class, we'll be giving a lot of fluids to your patient. We'll try to increase the BP of your patient before we proceed with the dilution process. Okay, so that's how important it is. Now, class, we also need to manage the increased ICP of our patients. So for increased ICP, we need to facilitate CSF drainage. CSF drainage can be facilitated by placing the patient on low Fowler's position. Okay, class, the low Fowler's position will be allowing for your jugular vein drainage. Okay, this allows, class, your jugular vein to drain the excess fluids from the to drain the excess fluid from your brain. Other than that, class, it would also allow for the movement of the CSF between the canal, okay, or the central canal, so which would allow CSF flow from your spinal cord and then towards your brain. In other words, facilitating CSF drainage. However, again, we need to be mindful not to elevate the head too high because that will result to brainstem herniation. Your mannitol class would have the same effect as your hyperosmolar therapy when it comes to fluids. Your mannitol and your hyperosmolar therapy will be pulling up the fluids or pulling out, the fluids from the brain itself going towards the intravascular space. Okay? Then the elevation of the head of the bed, as I have mentioned, should be in 30 degrees to 45 degrees. Sedation class is needed to decrease the oxygen demand of the brain. Sedation class may also be necessary if your patient is moving a lot, if your patient is not cooperating, or if your patient is very irritable. So for that reason, class, to help your patient or to decrease the ICP class of your patient, they need to be sedated. Your hyperosmolar therapy class would have high concentration or higher concentration. As I have mentioned, the same effect as your mannitol, it would pull out the fluids from the brain going towards the intravascular space. Then you also have your hyperventilation. Class, your hyperventilation would have the same effect, okay, class, as lowering your carbon dioxide. Recall, class, that when your patient has increased levels of carbon dioxide, that would result, class, to vasodilation. And then, class, with your vasodilation, with high levels of carbon dioxide would result to vasodilation, and then vasodilation would result to increased ICP, or intracranial pressure. So for that reason, hyperventilation is being induced to our patient for our patient to excrete the excess carbon dioxide in the body. But class, we need to be mindful that we need to watch out for the result of the ABG analysis. Okay, we need to watch out for the result of the ABG analysis to ensure that our patient is receiving the adequate amount of oxygen and carbon dioxide balance. Okay, so this will be showing on the ABG analysis. Added to that, okay, if our patient is hypertensive, antihypertensive therapy is recommended. Okay, we don't want our patients to have very high blood pressure. Okay, very high blood pressure will be able to lead to also possible rupture of your blood vessels. And then, class, a high blood pressure would not mean a good tissue perfusion going towards your brain. Okay, recall that you have your autoregulatory mechanism, and this still may be failing when the blood pressure is too high and too low. That's why you have your antihypertensive therapy to control the blood pressure of your patient. But in both the ICP and then the blood pressure, we don't want an abrupt decrease of both the ICP and the blood pressure. Take note of that. You don't want an abrupt decrease of your ICP and your blood pressure. Now, let's go to your stool softeners. Your stool softeners are, of course, prescribed among patients who have constipation. Okay, class, you are using your stool softeners because you don't want your patient to be straining during defecation. Again, we don't want patient to be straining during defecation. Straining during defecation would activate your Valsalva maneuver, and the activation of your Valsalva maneuver would mean that the parasympathetic response will be aggravated. If there will be aggravation of your parasympathetic response, there will be a decrease of your blood pressure, which is not very good to your brain. Okay, again, it will decrease your cerebral tissue perfusion. Okay, you might be wondering, oh, a decrease of BP will still decrease the flow to the brain. Yes, class. Okay, so it would abruptly decrease, okay, the blood pressure or the blood flow going towards your brain. So you don't want that also to be happening. So we need balance here. Okay, this slide, class, would help us differentiate the problem of a patient with right-sided and left-sided brain damage. So a right brain damage, class, or stroke on the right side of the brain would manifest with impaired judgment, impaired time concept. There will be impulsive and safety problems. There will be left-sided neglect. And plus, remember, since the effect of the brain going towards your peripheral aspect will be contralateral, so you would notice that there will be paralyzed left side, or there will be weakness on the left side of the patient. Class, the work of your patient may be rapid, but their performance is rapid, but their attention span will be short. Okay, they will have spatial perceptual deficit, and they tend to deny or minimize the problem. On the other hand, class, if the damage is on the left side of the brain, this would commonly manifest as depression and anxiety. There will be impaired comprehension related to language and mathematics. There is impaired right-left discrimination. There will be impaired speech and language aphasias. They have, class, the tendency to be paralyzed on the right side. Then, class, the performance tend to be slow, but they are cautious. Okay, so class, this differentiation of your left and right-sided stroke will be able to give us or mention to us the areas of specialty for your right and left side of the brain. Okay, so notice the differences. Class, when we are dealing with a stroke patient, a rapid assessment is very important for us to be able to identify patients who are probably cases of stroke. So class, organizations abroad have formulated, for example, the acronym FAST for us to identify quickly the signs and symptoms of stroke. So class, in the past it used to be FAST, but right now the update says it is be FAST. Okay, so for us to clear somebody for stroke, class, or to suspect that somebody has stroke, we need the be FAST assessment. So B, balance. We're checking if the person has a sudden loss of balance. Then you have your E, okay, sudden loss of vision in one eye or both eyes. Then you have your F, which is your facial asymmetry. Then you have your arm. This one arm weak or numb. So we have your arm drift for that matter. Then for speech, you have your slurring of speech or having speaking problems, having confused, okay, or appears to be confused when talking. Then you have your time. So class, the T there is just an add-on for us to be reminded the time is brain. Okay, and then other than that, the prognosis of the patient becomes good whenever class there is shorter period of time from the onset of the symptoms to medical management. Okay, so again, class, you have your B fast. Once your patient class would have any of these signs and symptoms, okay, it would be important for us to rush the patient to the hospital setting. And then if you have your stroke team, okay, inside the hospital, it's about time for you to activate your stroke team in the hospital setting. Now, so what are the phases of stroke class? Okay, there are two phases. You have your emergency or hyperacute phase, and then you also have your acute phase. Okay, so class, in these phases of stroke, emergency or hyperacute phase class, emergency measures are necessary. Hence, your stroke is considered to be urgent. Okay, urgent in such a way class that residuals or long-term effects of your stroke may be preventable if you are able to address the stroke right away or effectively during the hyperacute and emergency phase. So class, in these phases, treatment is necessary for your patient. Class, in managing a patient with stroke, the following diagnostic tests may be used. CT scan without contrast, then you have your arteriography. Okay, so class, by the way, CT scan without contrast is done because it is quicker. Okay, it can be done faster. Plus, your arteriography will be able to map the blood vessels to your brain. Your ultrasound Doppler may be needed to assess for your carotid arteries, to watch out for stenosis, and to watch out also for thrombosis. It would be able to evaluate class the percentage of blood flow or the percentage of patency of your carotid artery. Your MRI is of course more detailed, especially for talking about tumors. MRA class will be talking about your angiography. So this is usually done class if your patient will be undergoing invasive procedures towards the brain that would involve several blood vessels. Then class, you have your PET scan to evaluate the metabolism of the brain. And then of course your lumbar puncture to rule out for infection such as your meningitis. Now, prevention. Healthy high lifestyle class will be there always. Okay, look at the main risk factors of stroke. You have your diabetes and hypertension. So class, healthy lifestyle will be keystone in the prevention of your stroke. DASH diet. Your DASH is dietary approaches to stop hypertension. So dietary approaches to stop hypertension class K reduce the risk for hypertension, hence reducing the risk for stroke. Okay, it is also our goal to identify people or group at high risk for stroke and then to provide them education. Okay, class, stroke is a highly preventable disease but still among the most common cause of morbidity and mortality in the current. Now, medical management. Pharmacologic management. Your antiplatelet agents class are given in the form of prevention. Okay? If you are seeing patients, for example, who have atrial fibrillation, the tendency is that doctor is prescribing them class with clopidogrel. The doctor may be prescribing them class with clopidogrel or aspirin. So the purpose of your clopidogrel and aspirin is to prevent platelet aggregation. Okay, class, we also give your anticoagulant. Anticoagulants is for your anticoagulant would also prevent class the formation of your clots. Okay, now think, if your patient had already an hemorrhagic stroke, an acute stage of your hemorrhagic stroke, will it be wise to give these medications? Of course, it will be no. Okay, if you will be giving these medications to a patient who had hemorrhagic stroke, you are increasing the patient's risk for the recurrence of your hemorrhagic stroke. These medications class are particularly given for patients who have identified the risk. Okay, for patients who have identified the risk for your ischemic stroke. Okay, so that would be a patient with dysrhythmia. Okay, a patient with dysrhythmia. Now, criteria for TPA administration. You might be wondering what is TPA. Class, your TPA, okay, your TPA is the drug of choice for the management of your ischemic stroke. Okay, again, your TPA, your total plasminogen activator class is your drug of choice for the management of your ischemic stroke. Other than that class, your TPA is categorized as a thrombolytic. Okay, meaning class, it is able to dissolve the blood clot. Okay, now, since it can dissolve the blood clot, can I give this to a patient who had hemorrhagic stroke? Of course, no. Okay? Unless you would want the patient to be 6 feet below the ground. Now, criteria for TPA administration. Class, the patient should be 18-year-old and above. Clinical diagnosis of ischemic stroke should be there. time of onset should be 3 hours or less. Because class, if it's already beyond 3 hours, it's already futile or useless on the part of the patient. You're just giving the patient class the risk for bleeding without the possible benefit that he can get from your TPA. Other than that class, the systolic blood pressure should be less than 185 and diastolic is less than 110. It should not be a minor stroke or a rapidly resolving stroke. There should be no seizure at onset. And then your patient must not be taking warfarin sodium. Other than that, your patient should have the prothrombin time of less than 15 seconds or INR of less than 1.7. If these values class are very high, that would mean that your patient is already at risk for bleeding. So if you be giving your TPA therapy, you are doubling, tripling the risk for patient for bleeding. Not received heparin in the past 48 hours because also of the risk of bleeding. Then platelet count of greater than 100,000. Recall that your platelet is normally at 150 to 450,000. So class, if your platelet will be low, remember risk for bleeding. No prior intracranial hemorrhage, neoplasm, or AVM. Because class, this may cause a rebleed. If I will be giving thrombolytic therapy to your patient, it may cause a rebleed. Okay, look at that. No major surgical interventions within 14 days. Because that may also again result to a rebleed. Okay, no stroke, serious head injury, or intracranial surgery within 3 months. And then no GI or urinary bleeding within 21 days. So basically, class, we are assessing our patient for the risk for bleeding. Now, if your patient, class, okay, has the risk for bleeding, we are not proceeding with your thrombolytic therapy. Okay, we are not proceeding with your thrombolytic therapy because it will be more of risk on the part of the patient rather than benefit. Now, you might encounter patients class who, for example, is prescribed by aspirin and then later on would also be prescribed the thrombolytic therapy. Let us differentiate your antiplatelet, anticoagulant versus that of your thrombolytic therapy. Why is there a need for us to give an antiplatelet, anticoagulant, and add a thrombolytic therapy? Class, your thrombolytic therapy will be able to dissolve the clot. Okay, the actual clot that actually is blocking your arteries or blood flow going towards your brain. The purpose of the administration of your antiplatelet and anticoag class is to prevent further or future clot formation. Okay, these medications are not capable of dissolving the clot, but instead they are preventing further clumping of the blood. Okay, they are preventing further clumping of the blood. Now, if I would look at class your nursing responsibility in having a patient with stroke, okay, there's a lot. There's a lot that you can do for a patient who is having stroke. Okay, weigh the patient daily. Okay, monitor vital signs. Institute your airway management. So airway management class will be closely monitored with your ABG. Okay, class, there should be an ABG prior to mechanical ventilation. That would be the basis for your setup. And then, class, if we would want to know if the setup is working, we would usually have a repeat ABG 30 minutes to 1 hour after class the patient is placed on the setup. And then, depending on the pulmonologist or the intensivist, okay, a daily ABG monitoring may be done. Okay, your arterial blood gas. And then we closely monitor for the bleeding of our patient, especially if our patient had already your thrombolytic therapy. Now, okay, you may be also giving calcium channel blockers, again, to stop your vasospasm, hyperosmolar solution to reduce your cerebral edema, diuretic to excrete the excess fluid in the intravascular space, anticonvulsant and barbiturates for your seizure. Your barbiturates may also act as sedative to calm the patient. Now, surgery. Class, your surgery is used to prevent recurrence of your stroke or to restore blood flow. One common surgery that we can do for our patient is carotid endarterectomy. Class, your carotid endarterectomy is the removal of your atherosclerotic plaque. Okay? Removal of your atherosclerotic plaque, which is usually in the carotid arteries. Okay? So the risk class, if there is this atherosclerotic clot, okay, it may result to clot formation. Plaque, I mean, so that may result to clot formation. Okay, the clots here or the platelet would tend to aggregate on the fats. And then later on, class, may travel also to your brain. Other than that, if the atherosclerosis would persist, class, you are also decreasing the blood flow going towards your brain. Now, class, you have your extracranial and intracranial bypass. So this is usually done for occluded or stenotic blood vessels. Okay, so class, you have your extracranial, intracranial bypass. So class, if there is occlusion, just like how your coronary artery bypass graft would work for our heart. So the same class principle applies for our brain. Okay, so what happens here is that a stent will be placed for the patient, and then class, the stent will also be deployed to ensure that there will be enlargement of, or there will be adequacy on the diameter of your blood vessels. Okay, then class, if your patient had aneurysm or AVM, surgery is done. Okay, AVM class is arteriovenous malformation. Okay, so you have the following nursing care responsibilities for our patient. Altered cerebral tissue perfusion, so we need to address the increasing ICP. Impaired mobility, hence we need to prevent the complications of your immobility. Turn the patient, passive ROM. Self-care deficit, meaning we need to care for the patient. Impaired verbal communication, we may need to provide other ways for the patient to communicate to us. A whiteboard may help. Sensory-perceptual alterations, okay, so we need to ensure safety of the patient. Altered urinary elimination and constipation, we need to provide bladder bowel schedule for the patient, or the patient may be catheterized and stool softeners may be given. Impaired swallowing, so we need to be on NGT feeding at least. Okay, for us to ensure that the patient will not be at risk for aspiration, we need to place the patient on at least high Fowler's position during feeding, unless your patient is at risk for brainstem herniation. Then, for spasticity class, we may be using your dorsal wrist splint. Okay? For your flaccidity, okay, you may be using this kind of splint. Okay, so class, if you can notice for spasticity, the purpose of perhaps of the splint class is to try to restore the arm here on the anatomical position. For the flaccidity class, because of the weakness, it tries to support your arm. Now, you're also not allowed to acutely flex the upper thigh class. Acute flexion of the upper thigh may increase the intra-abdominal pressure and may acutely increase also your intracranial pressure. Okay, class, this is lying on the back and sitting in bed for a hemiplegic patient. Okay, so class, your hemiplegic patient may assume also class position changes. Then this is prone positioning to help prevent hip flexion. Okay, remember your patient is immobile. Hence, class, your patient will be having a risk for hip flexion. Okay, so these are just among the few interventions that you can do for your patient with stroke. Okay, class, that will be the end of our discussion on cerebrovascular accident. The next topic will be intracranial aneurysm. Up to this moment, I appreciate your effort and your attention. Thank you very much.